Professor Field is on. Welcome, John.
Hi, Terry. Good to see you.
And you. Thanks for dialing in.
And my good wife, Professor Anne Field, is also.
Oh, I did. Oh, you're both in. We are on it. Hi, Anne.
On the same computer.
Very good. Good. So we're up to 17 participants now and growing. So thank you all for dialing in. We're always a little bit overwhelmed by people being able to put, being prepared to put themselves out to dial into some of these things, but then it's a testament to the success and importance of the speakers that we have in some of these red series. So the first thing, an apology that I'm the one speaking to you now. Richard succumbed to a bit of a virus, and so we switched late on. So it gives me the great honor to introduce our two speakers tonight, who assure me they're going to do a bit of a tag team approach to what they're talking about tonight. So it gives me huge and enormous pleasure to introduce you to Dr. Yvonne Dailey and Dr. Deborah Moore. Both of them are consultants in dental public health at NHS England Northwest Public Health Directorate. And both of them, between them, have huge experience of trying to continue to address or to optimize dental health pathways, both in the NHS and academically, and continually and more as the years have gone on, chipping away at this huge inequality gradient that exists in this space. So I'm not going to say anything more. We're going to hand over to them as a matter of immediately so that we can hear from them. Usual ground rules, if you have questions as you go along, please put them in the chat. And then when they finish, I'm assuming they're both then going to be quite happy to take questions either from the chat or from putting your hand up as per the usual Zoom etiquette. So thank you both for agreeing to speak to us this evening, and I'm going to hand it over to you now, if that's okay. Thanks.
Okay, thank you, Terry. Hi, everyone. So I'm going to share the slides. So let's see. Is that working okay?
Working perfectly, Deb.
Yeah, great. So Yvonne is going to start. So I will mute myself and I'll move the slides on, Yvonne, when you're ready.
Debs, can I just interrupt? Just say to everybody, can everybody else mute as well whilst the talk's going on, and then we can open that up afterwards, and I'll do the same. Thank you.
Thank you.
Okay, thank you. So hi everyone, I'm Yvonne Dailey. So I'm the consultant dental public health, as you've heard, NHS England Northwest, and Deborah Moore, and Debs will introduce herself, I think, as we go through as well, or both in the same team. But before we start, we've also got to make a huge acknowledgement to Jill Oakley, who's one of our colleagues that actually works in the local authority, Chester West Chester, that's part of the Mersey and Cheshire ICB. And some of the work we're sharing tonight, particularly some of the data, is down to Jill's hard work that she did with myself in 2016, but that she's updated over time. So next slide, please, Debs. So I'm just going to take you on a journey really for the next few minutes, which is going to be way off what you normally get in these red lectures. May leave some of you scratching your heads, others thinking we're talking double Dutch, but what I hope is that we can take you on that journey that Terry's just described, that we are taking everyone on around the wider inequalities agenda, and how as a conglomerate and together we can tackle head and neck cancer, and particularly in our area, oral cancer, rather than for individuals at a population level. So in dental public health and the public health arena, what have we got out there that enables us to look at this agenda in particular? Well, as you'll perhaps be aware or not aware, very recently there was the publication of a national data atlas of health variation for head and neck cancer. That's published by DHSC, and the data through that follows our story this evening. We've all heard about Darcy in his most recent report, 2024, that State of the NHS. And screaming out of us again was the inequalities for cancer, cancer treatment, cancer access, and of course, head and neck cancer can feed into that agenda. Also, something that's more pertinent to the NHS, but the NHS Health Inequalities agenda and runs through the NHS 10-year plan is something called Core 20+5. So that is an NHS Health Inequalities agenda. Oh, someone's got a little one. +5 is the clinical priorities within that agenda, and cancer is a clinical priority within the Core 20+5 NHS Health Inequalities agenda. We have GIRF that many of you in clinical work will know, that getting it right first time pathway reviews. And then I've put some other things in there that set this scene that we need to always take account of. The NICE dental recall information and guidance for urgent care. Why? Because we know during COVID, urgent care and the urgent care algorithms might not have actually picked up people who had suspicious lesions that were relevant to oral and head and neck cancer. We've had published only this week, very recently, the NHS England Oral Health Care for Cancer pathway, for in which the treatment and the management of patients with head and neck cancer is in there for dental practices. And then you may wonder why we starred the last one, the oral cancer referral guidelines for dental practice. These were developed back in Cheshire and Mersey back in 2016, but still hold today. It's about early referral, prevention, and then the management of patients again that have had head and neck cancer. So within Cheshire and Mersey in the Northwest, we've got local guidelines and national documents that we can pull on to pull our story together. But our focus today is very much on Cheshire and Mersey. We will start with some of the head and neck cancer data, but move further towards oral cancer and reducing inequalities. Deb's, next slide, please. We're stuck. Okay, so quickly what we'll be covering today, we'll be looking at England trends of incidence of head and neck and then oral cancer and mortality. Then we'll look obviously at that data at Cheshire and Merseyside level, trends in inequalities of head and neck cancer, oral cancer by deprivation. I'll pick up further where we're going with that. Correlation between risk factors for incidence, which may very be different to the risk factors for mortality. And we're going to look at those at what we call local level, further down than the bigger Cheshire and Mersey level. And then how do we reduce inequalities in both incidence and mortality? Next slide, please, Debs. So just quickly, and apologies if people already know this, got to touch on what are health inequalities? What do we mean when we talk about that in my world? Health inequalities are systematic, unfair, unavoidable differences in health across populations and or between different groups within society. And it's really pertinent to remember they arise because of differences in conditions which we are born into, grow with, live in, work or age. And these conditions influence how not just that we think, but how we feel and act, and then have an effect both on our physical and mental health and well-being. And something, if you take that inequalities that we've just talked about and how we feel and we act, takes me back to conversations still with Terry, when I'm informed still patients turn up at A&E with head and neck cancer, oral cancer, fungating out of the sides of their faces, and you actually think, well, why? How does that affect? Why? What's going on? Why haven't they been told in their local communities? And if you look at the diagram on the left, this is the one I'd like you to hold in your mind as we go through the whole presentation, and look at the boxes. So equality is what we have for the NHS. Everyone, old, young, fat, thin, whatever grade, like I am now, is an equal access to healthcare. Everyone has that equality, that access to healthcare. But then there are those within that we're talking about here, where for some reasons their conditions are different. They're born different. They live in different places, work age, different sizes. If you look towards your right, we've all had equal access, but the little one on the end couldn't quite get over the fence. And so we have to help people get up and over the fence. And that's called the equity. And we'll look through the presentation today, talking very much about health inequalities. We know that there's equality there, everyone's got a box, but how do we get through the inequities in that? Thank you, Debs. Next slide. So here we're just trying to show, and please don't get fixated on all the figures, but look more, if you're visual, at the actual graphs. The graph on your left is the variation in head and neck cancer incidence by ICB. So they're the integrated commissioning boards, places that commission all the health services across England. And the graph on the right is the head and neck incidence mortality. And if those of you look at colours, the darker the blue, if that's how it looks to you, the darker the colour, the higher the incidence we have in head and neck cancer, or the higher the incidence of mortality. And you won't be shocked really to see that the incidence of mortality tend to overlay each other. And if we start to look at the data story that Debs will go into in a minute, they're darker the blue, the higher the incidence, the higher the mortality tends to become in our more deprived areas where we get these inequalities. But there are differences between incidence and mortality. If you look how we've pulled London out, why is the incidence not as high, but the mortality is higher? And we can look at that as well through a health inequalities lens. And that's the journey we're going to take you on today, our health inequalities journey, and how we can use the data and the infographics and our world to try and enable everybody to enable our population base in the end to decrease those risk factors for head and neck cancer going forward. Next slide, please, Debs. So quickly, let's just have a look quickly at those trends of oral cancer over time. And this data does look old, and it is older up to 2019. That's because at 2019, the data sets, the way it was collected was changed. But we can say, looking at the incidence, there was a 28% increase. And you'll know that from working in clinical work, 28% increase in the number of cases, the incidence of oral cancer. And the mortality had a 20% increase from the baseline figures. So we're still seeing, and I'm not telling you anything new, increase in incidence and increase in mortality. And that's across England. And as we go through the presentation, we're going to look at that in more depth across Cheshire and Merseyside, and then how can we help using these figures to actually target populations, patients, and try and move through and away from the health inequalities and deprivation that we have. Next slide, please, Debs. So what do we actually mean then if we think about the diagram with the people standing on the box, of which was equality and equity? What do we mean by the inequalities, and why in our speak do we always tend to talk back to the deprivation and inequalities? So we will talk about deprivation, and we look at deprivation when we look at it at area data, and we talk about the IMD, that's the Index of Multiple Deprivation. And that is built up of 7 domains. And those domains then become ranked, and their areas and their scores come together. And the 7 domains of deprivation which combine to create this index of multiple deprivation. So you will hear us talk through the presentation of the IMD, the index of multiple deprivation. It's not the same as poverty per se, because it's an index built up of domains. So income, the employment, the education, the health, the living environment, barriers to housing and services. We know that healthcare is not actually the biggest jump in making people healthy. We know that we're sitting in here now in Cheshire and Merseyside where we've got a world-class service, and I'm so proud to say that for our head and neck services. But actually, the people that are going to make more of an influence on your local population's health and head and neck cancer is not our world-class service. It would be more if we could do something about the deprivation, the housing that people live in, the crime rates, the living environment, their education and their employment. All those 7 factors of the IMD are all greater than what we can do on our own in healthcare. But we will talk now through the deprivation data, and it will be based on IMD, which has taken these 7 factors into account as we look at the data for head and neck and oral cancer in Cheshire and Merseyside. Thank you, Debs.
Okay, thank you. Thanks, Yvonne. Can you hear me?
Yes.
Yeah, fine. Hi, so my name's Dr. Deborah Moore, and I'm a consultant in dental public health in the North West team, working with Yvonne as well. So I'm going to talk through some of the data that we have available, published on Fingertips, which is our England public health data portal. And so first of all, I'm going to look at inequalities in oral cancer incidence, and this is the most recent data available. And so obviously with incidence, we're talking about new cases, and this is showing the incidence rate, which is age standardized across deprivation categories. And so the most deprived 10% of the country in terms of local authorities is shown by the most deprived there at the top, the most deprived decile. So each of these bars are 10% of areas. So if you look down to the bottom, the least deprived decile, that's the least deprived 10% of the country. And so what we can see when we look at this is that incidence rate in the most deprived compared to the least deprived is 1.3 times higher. And so we can say that in another way, we can say incidence rate is 33% higher in the most deprived compared to the least deprived areas. And this is upper tier local authority. And so just to kind of think about what that is showing, and this type of gradient is something that we see in almost every health indicator or health outcome that we look at. And what I want to point out is that there's a gradient there that kind of represents more or less favorable living conditions and environment and ability to look after one's health. And so we can see that across lots of different health outcomes. And another thing to note is that it's not just about very high rates in the most deprived groups. If we look even compared, say, the 5th most deprived, which is kind of in the middle, their health could be better if we could reduce some of the inequalities between them and the ones who are better off above. So this is not something that affects just the very worst off in society. Everybody except the most advantaged faces health inequalities. So that's a really important point to note, I think. And so the gradient reflects things like ability to access healthy food, ability to afford healthy food, stress in relation to high crime environments and the inflammation that causes in the body, ability to have access to good housing, even things like air quality varies according to levels of deprivation. And so they're the reasons where we tend to see these impacts on health. So if we're looking at mortality as well, so this is the same arrangement. So looking at local authority level deprivation, and we can see that with mortality rate, in the most deprived areas, it's 1.6 times the mortality rate in the least deprived 10% of areas. Or we can say another way, the mortality rate is 60% higher in the most deprived compared to the least deprived. And this is looking at inequalities over time. So this is for mortality. So what we're looking at now is the gap between the most and the least deprived. And so we can follow it from 2008 to 2017-19. And if we look at each of those lines there, we're going from the most deprived at the top to the least deprived at the bottom. so with the lowest mortality rates. And so we can see just from eyeballing the graph that the inequality, the gap between the best off and the worst off has actually widened over time. And just from looking at it as a quick eyeball, I think myself, it kind of looks as though it's increased maybe a bit more from 2011 to 13. But that's just from looking and not a statistical analysis. And so that's really concerning that those increases are getting wider, or those inequalities are getting wider. So that's for all ages for England. So I'm going to zoom in now on some more local data for Cheshire and Mersey. And so this is showing the similar data, the incidence of oral cancer by each of the local authorities or the councils, you would say, within Cheshire and Merseyside. And so each of the areas where there's a statistically significantly higher rate than the England rate is shown there with a star. So we can see that in Wirral, Liverpool, St Helens and Knowsley, there was a significantly higher rate of oral cancer incidence compared to England. And then looking at mortality, so this is similar data but a different graph. So again, we can see that the ones that were statistically significantly higher than England were Wirral and Knowsley. So if we look at the rate, the mortality rate there in England is 4.7. The rate in Knowsley is 9, so quite a lot higher. Knowsley is actually the second highest in England local authority for oral cancer mortality after Leicester. But again, there will be pockets of deprivation and high mortality and high incidence in areas that are generally less deprived or fairly affluent areas. So even within Cheshire East, which is down at the bottom there in terms of Cheshire and Mersey mortality rates, we know that Crewe potentially would have higher rates within that area because of higher deprivation. And so this gets us to thinking, can we predict using risk factors and causes that we know of? So of course we know some of the risk factors are smoking, alcohol, diet, HPV and age. And then some of these, not age, but some of the other ones will be related to deprivation and socioeconomic status. And so can we predict these local high-risk communities at a small area level? And this is the question that really underpinned the analysis that was done back in 2016 before I was involved, and then we've done an update now of this analysis for this presentation. So just coming on to it now, so we're looking at some of the data that's available at local authority level, which gives us information on risk factors. And so can we use some of these local authority level statistics to be able to predict areas of higher oral cancer registrations or new cases and mortality rates from oral cancer? And so Jill, who did this analysis, looked at the correlation between these area-based statistics and the oral cancer registration and mortality. And so I've highlighted the ones here that have come out with a moderate or a strong correlation. So a correlation of 0.4 to 0.59 is classed as moderate, and 0.6 to 0.79 is strong. So we can see out of the measures there that are available and that we could look at, the highest was for income deprivation, which is one of those 7 domains that Yvonne talked through within the indices of deprivation, the combined data. So that's just pulling out the income deprivation. And then also percentage of dependent drinkers, So that's the percentage within the local population. So they came out with the highest correlation, but also moderate correlations were for admission episodes for alcohol, smoking prevalence, and smoke 15 years and above, and smoking prevalence in adults 18 and above. So that's just showing that actually, although we know that drinking and smoking is definitely a risk factor, still underlying that, even more predictive, is deprivation, specifically income deprivation. And so that's where we talk about deprivation being the cause of the causes. And so we do tend to see correlations between those behaviours and deprivation as well. This is just now showing some of these correlations in a visual form. So if we're looking at on the left here, percentage of dependent drinkers with mortality rate from, actually, no, sorry, that's oral cancer registrations on the left. So that's new incident cases. And then on the right, we've got mortality rate from oral cancer. So we can see the shape of those correlations there. But again, as we were saying before, there is a correlation in itself between the behaviours and deprivation. And so this is pulling out alcohol-specific mortality by deprivation decile. So again, this is looking at 10% sections of local authorities. And so we see this gradient that we see so often, and again, goes back to living conditions, ability to have control over one's life, ability to access healthy coping behaviours and to change circumstances. So that kind of reflects that influence of deprivation on behaviours. So again, now if we look at income deprivation, so this is specifically the income deprivation measure, looking at incidence on the left, or new registrations, and then mortality rate on the right. And so the mortality rate graph, the top right data point that you can see there, the very furthest right and furthest vertical is Knowsley local authority. So just wanted to point that out again. As we said, the rates were very high in Knowsley when we looked at the earlier data. And so thinking about each of these local authorities within Cheshire and Merseyside, we can start to look at which are the ones that have higher deprivation. And this graph shows the proportion of the population living in each quintile of deprivation. So this is now splitting up the population into 5 categories of deprivation. And so the darkest blue, quintile 1 would be the most deprived. And so this is just showing the makeup of the local population and what level of deprivation they're living in. So within Liverpool, 62% of the Liverpool population live in the most deprived 20% of areas in the country. And in Knowsley, it's 63%. Whereas in England, this is how the deciles are created. It's split into 5. So the overall percentage who would be living at that level of deprivation in England is 20%. So that's the difference in terms of the local population and the level of deprivation that we see in lots of the Northwest and Cheshire and Merseyside as well. And this kind of reflects historic economic trends, post-industrialization, and things like that. So just in terms of the level of economic opportunity that's available within different geographies. This is just showing it in a slightly different way. It's just giving you the rank of deprivation and then the percentage of the population that are living within income deprivation. So again, we can see that Knowsley is the third most deprived local authority in England, and Liverpool is the 4th most deprived local authority in England. And Knowsley has the joint highest income deprivation in England. It's joint with Middlesbrough. So this is just showing it now in a map form. So this data is available at even smaller area levels. The darker purple here is showing income deprivation, that one of those 7 domains on its own. And so we can see clusters around central Liverpool, Knowsley, of the darker purple, which is showing greater prevalence of income deprivation there. So just something else to kind of point out is that what we're seeing here is that there are actually quite large areas affected by income deprivation. And so it's very tempting to be able to try to target smaller and smaller down to the street, but we see the large areas there. And this is what brings us back to knowing that we need whole population approaches to prevention, as well as the very, very super targeted. So I'm going to hand back over to Yvonne now.
Thank you. And I'll just give people a second just to digest all that information. And some that already work, and many of you in Cheshire and Mersey will think, oh yeah, well, we know most of our patients come from Knowsley, or most of our patients come from somewhere else, because just from numbers and deprivation. But what Debs has just shown you there, hopefully, is how we can use our data and other data to look at the wider context within the health inequalities agenda. So now I'm going to take you upside down, back to front. Hope you've all got your swimming goggles with you, on a slightly different journey of what do we do with that data. Everyone's working flat out. The NHS is at breaking point as we're here. Patients are still have head and neck cancer. Patients still have higher mortality rates, or secondary cancer again from specific causes. And so what do we do here? And we talk about preventing and reducing inequalities in incidence and mortality. And here we talk about upstream or downstream. Those of you who have read Darcy inside out and back to front will hear about Darcy talking about the left to right shift. And in a way, that's his upstream, downstream. And upstream is what can we do right at the beginning to stop people falling into a river of poor health? In other words, what can we actually all do? Primary prevention to prevent them ever getting head and neck or oral cancer. And then if we move down that diagram downstream, how can we pull people out if they've actually do have those symptoms of head and neck cancer? What can we do to prevent it downstream and make the impact on the total number of cases prevented smaller? Or how can we prevent the risk factors? So upstream, if we just think about again, is people never get there. We're all out of a job, hallelujah, yes? And downstream is okay if they have got there. How do we make the outcomes the best that we can for those people? Or how do we ensure, when we've given them the most world-class treatment and services, that their mortality rates are actually reflected in our populations, whether they're in a deprived population or an affluent population? Everybody is equal, like those blocks I showed earlier. Next slide, please, Debs. Now, this gets very complex, but if you try and look at the diagram, at the very top, we talked a minute ago about upstream, and the blue blobs to start with, and then the purple are your upstream interventions. Those that will hit the whole population. So we've talked before about the effects of income being one of our main predictors for the whole of the cause behind head and neck cancer, really. It was the main one in that IMD. So what can we do about income? Housing, we know, and crime and education. And come slightly down, if we had alcohol minimum pricing, smoking legislation, advertising for alcohol availability, they're the upstream things that we can do that. But advocate for national and local upstream measures, primary prevention, change the environment so that it's equitable. And therefore we should see a decrease in incidence over time if we can enable people to get out of the deprivation or put coping factors in, if we can enable them not to smoke, not to return to alcohol. And then slightly further downstream, there's the additions, and particularly we look at for head and neck cancer, the vaccination programs and HPV, those local smoking cessation services. So we've got a policy by government, but what to do locally? healthy food availability, welfare advice, alcohol cessation. And then we come further down again, what we call downstream, where the patient, yes, the person, the population do have the head and neck cancer, but how do we enable them to be treated within that circumstance? And if they are having the treatment, get the best value and benefit themselves from that treatment, because we'll look in a minute at the effects that deprivation can have, and therefore the reasons why those in the most deprived areas may suffer more mortality is because in that bottom orange, it might be that not that they haven't had the same world-class treatment, but that they then go back to smoking or alcohol, or they can't get the transport for the treatment. And that's the downstream. And downstream, if we can get that right locally, has probably more of an effect on our mortality figures against deprivation, and upstream has the effect on deprivation and our incidence to start with. So upstream, we're stopping them falling in the river, as we said. Downstream, we're catching them and doing the best we can to make them live longer and healthier lives. Next slide, please. And so examples of that upstream, downstream. On the left, yes, all of you that can see that it's the ash from Wales. Those that you don't know me know I live in Wales, so of course I'll pick this out. But this is upstream, and it's talking about tobacco and the vapes bill. You know, smoke-free future for children, protecting young people, retail licensing. If we can get that across the whole of UK, it will have an effect on our most deprived communities. And that's that upstream advocacy, which we, as we know, smoking with the alcohol and with vaccination would have a great effect for head and neck cancer. And if you move to the diagram on the left, I always roll my eyes when I see this, because at the moment, CVD, quite rightly, is that one of the main pushes for the NHS and health checks is all around CVD. But when you look behind this diagram, positive behaviour change preventing cardiovascular disease, we could just put vaccination on the side. Positive behaviour change preventing head and neck cancer. It's the same thing, slightly downstream, enabling people to eat healthily, stop smoking, enable their drink intake to be moderated, maintain healthy weight. And if we had vaccination there, that would give us more of a downstream effect, both on our incidence, but most definitely on mortality. If we've caught somebody early and we can make sure that we've got all the other factors in, we will prevent those high mortality figures in deprived areas, and it should become much more equitable across the whole of Cheshire, Mersey and England. Next slide, please, Debs. So let's take just an example of a targeted support to reduce inequalities in mortality, that downstream. What have we found? What did this paper tell us in a public health point of view that might have looked differently to ourselves in clinical world? This is one of your colleagues recently, Rachel, and many of others on the call, that undertook this piece of work looking at the socioeconomic deprivation correlates with incomplete radiotherapy treatment for head and neck cancer. Now, in my world, and excuse me, you know, if we're going to have a patient with head and neck cancer, and we know we're in a world-class area here, they will get the best treatment you can give them, wherever they're from. But what this paper showed was those that had come from the more deprived areas, unfortunately, didn't complete their radiotherapy treatment. And therefore, if you think what I said a minute ago about downstream things we can do to help downstream will help mortality, if they're not completing their radiotherapy treatment, then their risk of mortality from head and neck cancer is going to rise. And why weren't they completing that treatment? Some had to rely on hospital provided transport that perhaps didn't come at the right time, didn't turn up, they weren't ready for it, didn't get on the hospital transport. And why was that? Well, we know 40% of households in Liverpool don't own a car, so they had to rely on the hospital transport. And many were living in areas of deprivation, especially high crime domains, as we've touched on before, which will have an effect on their ability to turn up for treatment, even if we give them the best treatment possible. And if they're not coming for the treatment at the right time, each time they will miss their fractions and their outcomes will not be as positive. And in this paper, it showed all the holistic approaches that staff used to try and enable the patients who missed their fractions, gave them psychological support, welfare checks to encourage attendance, all the downstream measures we can give to our patients, or in my eyes, our populations, because we don't work in our world in a one-to-one. We will be looking at that population. What can we put in place to catch them if they're in the stream, to ensure they get the best outcomes from that treatment so that our mortality rates in the most deprived areas are equitable? And those were some of those holistic approaches described in the paper. Next slide, please, Debs. So how, if we're trying to sum up, do we prevent the maximum number of new cases and reduce inequalities in incidence mortality? We have got to all work together upstream and push at government level and with policymakers and with our directors of public health to work at that population level to create that healthy living working environment for all, the fairer living and working conditions, policies for food, labour, education, welfare, etc., legislation for smoking and alcohol, and I would say on there then slightly in the middle to enable vaccination programmes to take place and to enable those to attend that need to attend. And we do need to work more with our disadvantaged communities and groups and individuals, an additional targeted downstream approach so that they achieve those same health outcomes if we need to treat them, because as we know, if not, they will become those with a higher mortality. And universally, we need to look with varying levels of support in proportion to need and risk. So whilst we said it was equitable access to NHS healthcare, we know if you go back to Darcy and the core 20 that I spoke to in the beginning of the presentation, we will need to put in various levels of support for the people who live in our more deprived areas if we are going to, one, release those trends of mortality related to deprivation, and two, decrease the incidence in head and neck and oral cancer across Cheshire and Merseyside. And I would say that is the call for action, to work together with your public health consultants, directors of public health and directors of population health within your local area. Thank you.
Yvonne, Debs, that was a really truly outstanding tour de force talk about the whole of this area, which is so important for us to increasingly take into account, as you know, from the conversations that we've had. Are you happy to take some questions that will either hopefully come through the chat or otherwise? So
yeah.
to the rest of the delegates, please type some questions in, or stick your hands up and I'll try and pick you out as we go along. I guess the question from my point of view is where do you start with all of this stuff, isn't it? I mean, those data are, on the one hand, you know, hugely illuminating, but actually really, really startling. You know, as we did when we did this in 2016, we thought it was bad. And you might start thinking there might be improvements now, but this is beginning to become really, truly shocking. And for me, there's this dichotomy, isn't it? Is that you're looking at population, and I'm talking about UK population data, where you're hearing smoking's going down and larynx is going down, and, you know, all these smoking-related diseases are beginning to reduce. But actually, when you really drill into these smaller static populations, these aren't shifting; they're getting worse, aren't they? And then for me, then that leads to a very broad two-pronged approach, isn't it? Because once you have to have these gross public health effects that you've just described, there is a targeting issue of this. And where do you draw the balance there? How do you do that?
It's a great question, Debs. Do you want me to just?
No, you go. Yeah.
It is that academic question. I think you're totally correct, Terry. You've got to target, and if I just put an NHS England hat on for a second, and that targeting is what the core 20+5 is really all about. It's about targeting your 20% most deprived areas, they say in England, but within the Northwest, we then say we target our 20% most deprived areas within the whole of the Northwest, so Knowsley, Blackpool, etc., for many disease processes, not just head and neck cancer. We are doing exactly the same with a huge programme for children in Cheshire and Merseyside, supervised toothbrushing programme, targeted at the 20% most deprived within each local authority currently, for the reasons you've just outlined.
Thank you.
Yeah.
John, you've come. Oh, sorry,
sorry,
no, please add
just
in.
to add as well. Yeah, no, I think it's sometimes can be overwhelming, can't it? You know, when you look at these data and you think, where do we start? What can we do? And I think it's important to reflect that that's where partnership comes in, and different people can affect change at different places on that upstream, downstream. And I suppose it's just bringing together a coalition of the willing, I think, to start to think that through and to think about some of those more targeted interventions. And, you know, myself as a public health person, I instantly think more about the upstream, but you'll know the detail of the treatment pathway and all of those points where people can face inequalities further down the line. You know, the transport example is one really good example, and I think that's where you need that community of practice to kind of really have the biggest impact.
That's really helpful. I mean, just before I let John in, so, you know, Yvonne, you're very well aware of my own personal journey of thinking about the nitty-gritty of operating on people through to later on, how do we get really upstream? And I think then there's a journey for the Head and Neck Centre to really accept that journey for itself, because ultimately we are going to have to engage much more with the politicians in its broadest sense, isn't it? Because unless some of those real upstream things are affected, none of this will actually change.
No.
John, you came online and presumed you got a question, have you?
Thank you very much. Can you hear me? Yes?
Yes, we can.
Excellent presentation from both Yvonne and Deborah. I started my life off in head and neck cancer research now, and lung cancer. And in fact, I can see the parallels going across. And in fact, your IMD group is exactly the same as we have in lung cancer. My sort of recommendation is that, in fact, the various screening groups need to work together, be it breast, colon, cervical, lung cancer. Unfortunately, they all act quite independently at the moment. But we actually all have exactly the same risk groups as in the same IMD groups. However, the good news, if I can put it, once you've identified these IMD groups, we ran the UKLS lung cancer screening trial, and just this year, we published the link between IMD and outcome, which was published in Lancet Regional Health Europe, if you're interested. But the thing is that individuals that were in the lowest socioeconomic group that were within the CT screening group, their outcome was as good as the people at the top. So therefore, what we need to do is how we identify these individuals. Well, I was involved in a risk model. In fact, Caroline McCarthy was developing a risk model for head and neck and oral. Okay, we need to develop that further, but we do need to be able to identify these high-risk individuals for potentially future oral cancer screening. But I think the good news is that once we can identify them, they actually do gain as much as the people at the other end of the IMD group. And my plea is that actually we start to learn to work together. We're identifying the same group and we need to target the group. So when they actually come in for maybe lung cancer screening, have you actually recently been seen by your dentist or whatever terminology we want to use these days, or in fact, be it breast and colon screening. So I think you focused very much today on oral cancer, but I'm sure Yvonne also has a much wider role as well. And I think if one can bring these various communities together, we could gain quite a lot in the let's say, Cheshire and Mersey region. Thank you again.
That's really astute comment. And in fact, when we started talking about this, John, obviously Liverpool has a real rich heritage in public health research and delivery. And actually the risk factors around, for example, cardiovascular disease and stuff like that, it's flicking the dial to just look in a cancer direction. So, you know, I think all of that is very right. There's a question in the chat. Is there any correlation between deprivation and the industries that people living in such areas typically work in? Is exposure to certain materials in the work environment a factor?
Oh,
Not that I know of. I don't know, Yvonne. Do
no,
you?
not that I know of. I'm
Great
trying to think.
question.
It is, and I'm thinking back to Professor Field there, you know, thinking lung and you could make that. And then I would look if Richard was here and ask him about the genetics behind it. But what I would say is if you think about the things we've put into the IMD, the industrial working area where there are many, there weren't as many blue collar people, then yes, if you turn it on its head and not think about the industry that they're working in, but what they did within that industry and whether they did work and where they were within the whole career structure, if that makes sense. So you've got that same common risk going back down to where they live, how they work, how much control they had over their own lives, whether you're sitting on a production line day in, day out, not having any control, to whether you're directing something. But actually down to the role and the works, whether it's where you are now, let me think, somewhere like Runcorn that had the big ICI factories, or the chemical works. Yes, there will be, and there are for some cancers, but I can't say that for head and neck cancer. Sorry, that's not where I've ever gone in that. One would look at the actual working lives of those people and where and how they worked through the system, and if they worked at all.
Thank you. We could carry on talking about this all night. I'm going to ask you one more question, actually. So looking forwards, okay, and if we're trying to influence politicians with what we assume, which I think is incorrectly assumed a lot of the time, a cynicism to invoke some of the changes that might be required. If we look at your data, and you've got a really strong correlation, obviously with socioeconomic deprivation, obviously with drinking habitus in its broadest sense, and we can have a conversation of what that really means. And vaccination, obviously, as a preventive measure, particularly for HPV positive disease. So if we look down the track, gender neutral vaccination is already invoked, and the modeling data predicts that that will probably start kicking in 2045 if it's as effective in cervix as it has been in cervix, which isn't a huge amount of time off. We've still got people to manage in that period of time. And then my real question is around what I read in the popular press about the drinking habits, for example, of Generation Z, Generation Z, which is undoubtedly dropping really quite markedly. So do you have any thoughts about how those two things might feed into this? And if it was assumed that they would have an effect, how much would that impact on influencing politicians at that point? Would they actually just say, well, it's going to happen anyway and kick it down the track? How in your world, what's the effectors of that?
Yvonne, do you want to go first?
I'm trying to think of the effects there, and I'm thinking that without treading too far into the political line, because we know things can be here today and gone tomorrow, I'd say COVID vaccine, for instance, don't we? And those sorts of things, or onto the other lines that Deb and I work in around water fluoridation, the politics of that. But we know, like you just said, Terry, water fluoridation, if I just take it a different way, would improve oral health. But it comes in favour, out of favour, and there's a lot of politics. So I would say to them, take your vaccine, take the smoking. And we don't know whether they're up and down in favour or not in favour. But what we can say is we still need to push for those now, because we don't know the effect of age, do we? So even if we get vaccination, even if we get smoking, even if none of us touched alcohol ever again in our whole lives, what else is going to hit us after that? So that we still need to work, I think, in those same parameters of working together, keeping the politicians on track so that they don't, as you say, oh, well, we're vaccinating everyone, so it won't be from vaccine and they'll all stop smoking. I think we need to get behind it and keep pushing it still now. And if you took Cheshire and Mersey, you've got a push at the moment for something called Altogether Smoke-Free Cheshire and Mersey. And everyone is pushing from various partnerships. That's where I'd see your head and neck centre getting involved with chance to push that as far as one can. So I've not fully answered your question, because I think it would still do this. Something might come left wing, and we need to keep pushing them for the main things that they know, the smoking, the alcohol, and working around those deprivation indices at the same time, particularly that cost of living crisis that we hear the dramatic effects that that has on people.
Listen, thank you so much. I'm really minded of the time of an evening. I'm grateful to you to giving up your time to come and talk to us. I think it's a testament to your talk and the interest that it's generated that nobody's left this as far as I could see. So thank you so much. I'll close the meeting now. But I'm so grateful to you for opening us. It's so much food for thought, really stimulating. Thank you so much.